Good morning, everyone, and welcome to our ongoing COVID-19 webinar series, where we're bringing you scientists and stories around the pandemic, hopefully cutting through some of the noise that's out there. We're so excited that you've been joining us all along. We've been going on 3 months now with this webinar series, almost 3 months. So welcome to the Denver Museum of Nature and Science at Home. I'm Kristen Uhlenbrock. I work at the Institute for Science and Policy, which is a project of the Denver Museum of Nature and Science. So together with the museum and our partners at the Colorado School of Public Health, we've been able to bring you this series. So a few housekeeping items before we get started. Of course, if you missed any of our previous episodes, we have written recaps and recordings on the Institute website. Just go to institute.dmns.org. You can find all of that information. Feel free to send that along to folks who you think may be interested in reading and listening to some of our past episodes. We've had a slew of issues, everything from talking about vaccines to mobility to impacts on different communities. So go ahead and look at that information. If you're joining us here on Zoom, welcome. We always have a nice big audience tuning in on Zoom. You can ask your questions right there in that chat feature. If you've been chiming in, letting us know where you've been tuning in from, that's the same place you're going to ask your questions. We encourage you to really think thoughtful questions, send them in. We see all of them. We try to incorporate all of them as we can into our Q&A. If you're joining us on Facebook Live, welcome from over there as well too. For there, we're also looking at your questions. Just go ahead and drop them into the comment feature and then we'll pull them over here into Zoom and take a look. So today is going to be very special. It's going to be very much audience driven, very few presentations. We actually have only a few slides here at the beginning, and then it's going to be really robust conversation and dialogue. So we're going to really look to your questions to help flesh that out. We're also going to go for about an hour today because we have 3 speakers and this topic is really big and we're nowhere near going to do it justice and even in the hour that we have. So this is the first part in a 2-part series where we're talking about racism and inequalities and COVID-19 and some of those kind of intersections between all the 3. We have had long-standing systemic both healthcare and social inequalities, which has really led to some disproportionate impacts on racial and ethnic communities as it relates to COVID-19, regardless of age. According to the CDC, these groups are experiencing higher rates of hospitalizations and deaths, often more so than non-Hispanic whites. So to understand our current pandemic and its impact on these communities, it's helpful to look at kind of how we got here. So the first part in today's series of 2 parts is going to start to explore some of these questions. And so we'll go through them today as well as kind of continue on into next Monday. We're going to be talking a little bit about the history of healthcare inequality, some of the trust and mistrust of health practices, some data from the current outbreaks, as well as possible ways forward. So I have 3 wonderful guests who are both not only wonderful medical practitioners and very distinguished careers, they're also community leaders, and I've gotten to know them here recently, and they're very lovely people. So let me try to introduce all 3 of them, and I'm nowhere going to do justice to their distinguished careers, but this is a little bit of a start just to get you a glimpse of some of their background. So one of our first speakers is Dr. Fernando Alguien. He's a professor of medicine in the Division of Pulmonary Sciences and Critical Care Medicine, and the director of the Pulmonary Translational Corps and the Asthma Clinical and Research Center at the University of Colorado Hospital. His research interests include asthma, the role of obesity in asthma, as well as mechanisms of disease. I even had read, some of his work that he'd done on air pollution impacts. So he's definitely a lungs guy, which I think is probably really important here to COVID-19. He's also the director of the CU School of Public Health's Latino Research and Policy Center that works to eliminate health disparities among Latinos in Denver and beyond. He's worked at the Centers for Disease Control and Prevention, Emory University, University of Pittsburgh, and La Salle University School of Medicine in Mexico, which I think is his alma mater as well. His publications, awards, and mentoring experience is really extensive, so I'm not even going to do it justice mentioning any few of those. Our other speaker, of course, is Dr. Cerise Hunt. She's the director for the Center for Public Health Practice, assistant professor in the Department of Community and Behavioral Health at Colorado School of Public Health, and the past president of the Colorado Public Health Association. Cerise was instrumental in the formation of the Colorado Black Health Collaborative. She's also a founding member of Healthy Babies, Strong Families, Healthy Start Community Action Network, where this initiative is committed to the reduction of African American Black infant mortality rate and the promotion of positive birth outcomes. Ceresa's research and practice explores topics related to diversity, equity, and inclusion, organizational change, health equity, racial and ethnic health disparities, community outreach, and mobilization among diverse populations. She also has a very extensive CV like all of our speakers do. Our third guest is Dr. Sparrow Manson, Pimbana Chippewa. He is Distinguished Professor of Public Health and Psychiatry. He directs the Centers of American Indian and Alaska Native Health and occupies the Colorado Trust Chair in American Indian Health within the Colorado School of Public Health. He is a medical anthropologist, which I find quite fascinating. His program includes 10 national centers, which pursue research, program development, training, and collaboration with 250 Native communities, spanning rural, reservation, urban, and village settings across the country. Dr. Manson has acquired over 200 million in sponsored research to support this work. He's published more than 280 articles and book chapters on the assessment, treatment, and prevention of physical, alcohol, drug, as well as mental health problems over the developmental lifespan of Native people. He's also very well recognized with numerous awards, and he's widely acknowledged as one of the nation's leading authorities in regards to Native and Indian health. So I am very privileged and honored to have all three speakers joining me today. And I don't want to take up any more time with me talking. So let me turn this over to Fernando to kick us off with just a few slides and an introduction to the topic.
Thank you, Kristen, and thank you for the organizers. It's really wonderful to be here with you and to really speak to a very important topic regarding COVID. So I'm just going to show a few slides to really highlight some of the issues that we're experiencing right now. So I'm an ICU physician, and one of the things that struck me as really interesting and really odd was when I walked into the unit just a couple of months ago, we had 6 ICUs just dedicated to COVID patients. And it was really striking that I've never in my whole life been in an ICU where everybody shared the same disease and most of the patients were Hispanics like me. It was really quite striking. And here you can see the nurses used to put pictures on the window. This is one of the COVID monster outside of a patient's room, but most of them were messages of hope. And certainly that speaks to our data at UC Anschutz Medical Center, where you can see here the first 200 hospitalizations in the proportion by race on this graphic. Only 20% of them were white, whereas more than 30% were Black and almost 30% were Hispanic. So Hispanics and Blacks accounted for more than 2/3 of the cases, which is really quite striking considering that the state in Colorado, Hispanics comprise 22% of the populations and Blacks 4.8% of the population. So huge overrepresentation of the disease burden in these populations. Certainly when we started seeing this data coming early on from New York, you can see that the same thing was happening. This graphic from the New York Department of Health and Mental Hygiene shows that both African Americans and Hispanic Latinos are most likely to be infected in the non-hospitalized blue bars here on your left, are also more likely to be hospitalized, and are unfortunately more likely to die compared to Caucasians. And this is from the early epidemic in New York. And recently a paper, an article that was published by the New York Times showed, data compounded up to now that compared to whites, Blacks and Latinos really represents about 2/3 of the cases. What you're seeing here is Blacks comprise 62 cases for 10,000 people infected, and Latinos 75. So it's really quite, again, nationwide and overburden of the disease for COVID. And what's striking about this article is you can see here again, the coronavirus cases per 10,000 people by age and race. And one of the things that is really quite striking is that compared to whites, the Blacks and Latinos that are mostly affected are on the sort of working younger age population. So this is not that the elder Latinos or Blacks are being more affected, but it's actually the working population that seems to be at higher risk. The virus doesn't discriminate, but governments do. And so I think a lot of the issues that relate that we're seeing why Blacks and Latinos are being impacted more seriously about this disease, more than genetic susceptibility or biological susceptibility, has to do as a consequence of structural and systematic racism and inequalities in our society. The CDC has acknowledged some of these factors, and if you go to the website, you can see certain explanations as to why certain ethnicities and race groups have increased burden of disease related to COVID. So for example, these are just some of the ones that I think are worthwhile to mention during our discussion today. Many members of racial and ethnic minorities live in neighborhoods that are further away from groceries and medical facilities, so they have to go out and walk. Many live in multi-generational households, often many people in very close living spaces. And they're more likely to live, Blacks and Hispanics are more likely to live on densely populated areas with higher outdoor air pollution levels. And there's some very interesting data showing that air pollution may be a risk factor driving mortality rate in COVID. And we can talk about that as well. And then, racial residential segregation linked to a variety of adverse health outcomes and underlying health conditions, such as practices like redlining and structural racism, which plague our communities. And there are many work circumstances. The majority of Black and Latino workers are employed in service or production jobs that for the most part cannot be done remotely. So as you've seen before, there's a lot of mobility in this group and exposure. Although Hispanics account for 17% of the total employment, they constitute 53% of the agricultural workers in this country. And don't forget that people like Blacks and Hispanics are critical workers that make everything happen, from hospitals flowing to groceries being stocked to all the service lines happening, and they're the ones that are being impacted the most severely. Unfortunately, this is a phenomenal piece that I recommend everybody to read. It's called What is Owed? Time for Reparations in New York Times Magazine, June 2020. It's a phenomenal paper that's worthwhile reading. But one of the things it ends up with is that it's really kind of a bleak future, considering that today already more than half of the Black adults are out of work, Black businesses are withering. Just 12% of Blacks and Latino businesses owners who applied for the small business loans received the full amounts they requested. So even in the aid package, we see biases and racism practices applied to the groups that have been affected the most. So I think unfortunately for these racial and ethnic groups, the road is long ahead. And thank you so much for your time.
Thank you, Fernando, very much for that. We have some staggering statistics in there that hopefully we can unpack a little bit more here later. I also will let folks know, we'll take a link for that article and we'll send it in our follow-up. Thank you, so people have a direct link to read that. Thanks for offering that up. Okay, we've got two other speakers who are going to provide some more remarks here about how COVID-19 has impacted different racial and ethnic groups. So let me turn this over to Dr. Cerise Hunt.
Okay, well, good morning, everyone. And so my focus is going to be really looking at how has COVID impacted the Black community. And as Fernando has done a great job really setting and teeing this up, what we know about the Black community on a national level that, you know, we make up about 13% of the country's population, but account for 22% of the deaths. And this is according to the CDC. So this is a result of what I'm going to refer to as some pre-pandemic realities. When we've talked about this, this shouldn't be alarming. This shouldn't be surprising. And this is due to the longstanding systemic health inequities that have put members of the Black community at increased risk of getting COVID-19. And so I know our title is talking about inequality, you know, and that's in our title because we're talking about those differences. But what in order for me to authentically talk about the Black community, I got to address inequity, the injustice, the unfairness, as Fernando has already stated. And because it's the inequities that lead to inequalities. And so that's the lens, as we're thinking about what we need to do, how we're going to address, we know the disparities. And I'm going to, you know, we've talked about the disparities. We really needed to look at the inequities that are perpetuating a lot of groups of color. So what's foundational in the inequities is racism. And I love Dr. Kamara Jones, who with Morehouse School of Medicine, former American Public Health Association president. She has done a lot and just a tremendous public health scholar, a scholar on anti-racism. She's given us a framework to really think about contextualizing racism. And it's a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is race. So that's what we're talking about, is race. Now, this system that has unfairly disadvantaged some individuals and communities and unfairly advantaged other individuals and communities. So when I think about racism, which really is really going to be a lot of my focus, it's rooted in the foundation of the United States of America, beginning with the enslavement of Africans in 1619. And if we really think about most of the Black experience in America has been endured under chattel slavery. That was 244 years. It ended in 1865. And in this time, we got to remember, Black folks were thought of as property. We weren't thought of as inhuman. You know, we weren't thought of as human. And then after slavery, then we go into the Jim Crow laws, you know, and those were that collection of state and local statutes that legalize racial segregation, which is a common theme. We heard segregation already in Fernando's talk. So for about 100 years, we were in this Jim Crow period, from, you know, the post-Civil War until 1968. And what we need to understand is that those laws deny Blacks the right to vote, hold jobs, get an education and opportunities. And so when we think about, you know, redlining and, you know, the New Deal, you know, all of these government sanctions that were supposed to uplift the economy, uplift folks, the Black community, because of racial restrictions, was denied these opportunities of things as home ownership, which leads to wealth, which leads to accumulation of wealth. So when we think about how we got here, we have to know our history. And then the Tuskegee experiment. And I think, you know, which was sanctioned by public health from 1932 to 1972, which really, would also ruin the lives of many Black folks. You know, men were recruited for the syphilis study, were not given informed consent, and they were not given adequate treatment. So now here we are with COVID. Now we want to start going to folks' going door to door. We have contact tracers. We have folks that we want to get antibody tests and all these different things going door to door. There's a lack of mistrust due to the historic aspect. And so, like I said, when we're thinking about our interventions and being culturally responsive, we have to understand that trust is a reality in it. So I would just like to say it's not because of one's race that this is happening. The virus isn't going after Black people, as already been stated. It's because of inequities and racism, which leads to poor health and greater exposure to the virus. And so when I think about COVID-19 and the Blacks are more likely to become infected, well, like has already been stated, we're exposed more. We have those frontline jobs, which are now deemed as essential, but with these frontline jobs, they're low paying. And like has already been stated, it can't be done from home. But what we also know with the Black community is once infected, more likely to die. Blacks have a higher rate of underlying conditions such as diabetes, asthma, high blood pressure, and this extra burden of chronic disease makes COVID-19 more dangerous. So then my next question is, well, why are the Black community overburdened by chronic disease? Like, you know, what's the explanation? And we have to take into consideration the physiological aspects of racism. There has been an increased acceptance in medicine, you know, of a concept called weathering, pioneered by Dr. Arlene Geronimus out of the University of Michigan School of Public Health. And in her research, it holds that the stress and the living as a member of a community of color in itself takes a toll on the body. So when we're talking about that experience of racism and discrimination and prolonged exposures to the indignities and dangers of discrimination, it's weakening, you know, one's cardiovascular immune systems. And all of this leads to accelerated deterioration of the body. And then also, we also know that there's less access to healthcare. In 2019, the Colorado Health Institute reported that although the Affordable Care Act has provided Black Coloradans more access to health insurance, this does not guarantee that they receive services, treatment, or equitable care. So here we go, there's that buzzword, equitable care, we team into the inequities. They are less likely to report seeing doctors and specialists and are more likely to visit the emergency room for non-emergency visits. So then we got to go into the trust of the healthcare systems. Are they going to receive the quality of care? We also know that access to care is, you know, is not the only barrier. Studies have found that implicit bias on the part of healthcare provider often results in poorer treatment of Black patients. So, and I would even say when we think about bias and the treatment of Blacks, we have to go through all of our systems, because we know in order to eliminate these inequities is we're going to need a multi-systemic approach. So we need to think about our school systems and the inequities, because we can talk about the school to prison pipeline and fear of teachers, of Black students. So there's this whole racial bias is real, and we need to tackle this and address this. And then there's also the myths that lead to inadequate treatment in the Black community, such as, you know, such as one that is Black people don't feel pain. There's a whole study entitled Racial Bias and Pain Assessment and Treatment Recommendations and False Beliefs About Biological Differences Between Blacks and White. And this was led by Dr. Kelly Hoffman at the University of Virginia. And this work really reveals that a substantial number of white lay people and medical students and residents hold false beliefs about biological differences between Blacks and whites, and demonstrates that these beliefs predict racial bias in pain, perception, treatment, recommendation, and accuracy. It also provides the first evidence that racial bias and pain perception is associated with racial bias and pain treatment. So this mistrust in healthcare system has multiple factors. And so I do want to stress that. And we've done our own work within the community where we're here of individuals, and I partner with the Colorado Black Health Collaborative, where we were in the community and the community was telling us our provider doesn't listen to us. It's like they don't hear our concerns. So we have to really understand that we are delivering our services that are culturally responsive, that we are being inclusive to the needs, and we're listening to the community. So before I hand it over to Spiro, I just want to sum up. Race is not a determinant of COVID-19. I can't stress that. It's racism. And so inequities in COVID-19 pandemic and the uprising and police violence and killing underscores that racism is a U.S. crisis. And I'm so great that there's so many people that are watching and tuned in, because in order us to stress this crisis, we need all of our attention right now. I don't care what sector, not only in our public health and healthcare systems, but our education, housing, justice, our behavioral health and employment systems. And then and Kristen, for real, this is my final statement. We can never forget and minimize the strength and the resiliency of the Black community. So even with this bleak history and the challenges, Blacks have persevered when faced with continuous adversity and injustice. We are resilient. And I'll hand it back to you, Kristen.
That's not going to be your final point. We've got much more.
You know, it's not. I'm just
you.
letting you know. I'm just playing nice. I'm just playing nice right now.
You're like, I'll take a moment to pause. We're going to come back to a lot of what you said too, and expand that. And I definitely want to end at some point on talking about the resiliency with all communities here. So that's a really nice point to keep in mind for later. Let me turn over to Dr. Spiro Manson. Spiro, would you like to provide some opening remarks for our audience? Let's unmute you. There you go. Thank you.
I am. Ani Bonjour. Thank you, Kristen, very much for the opportunity to join you, the museum, and the broader Colorado community in this important conversation. I'd like to begin my remarks by sharing with you an observation that was shared with me in turn in mid-February when I last visited and worked with some of the Alaska Native constituencies there. And it was as follows, quote, "Once more, darkness descends upon our people in this land. It bears many names: smallpox, the flu, measles, typhoid, TB. Today, a virus. Suffering and death always follow, yet our traditions shine brightly, casting light to guide the way. We again struggle to survive, buoyed by these traditions, now armed as well with medicine and science, weapons of the Western world. The challenge is how to bring both to bear on this danger so we may live on." And that's from an Athabascan elder translated into English. He lives in the interior Alaska. And I think as these powerful words of this particular elder underscore, this novel virus sweeping across our country has reawakened the fear, pain, stigma, and loss of past outbreaks of infectious diseases among American Indians and Alaska Natives. It amplifies the fractures in the social fabric only recently covered over, and exacts a terrible toll by exacerbating the health disparities that place this special population at added risk. What are some of those? You've glimpsed them as the public in general, largely through the eyes of the Nene or the Navajo Nation in the Southwest and the Lakota of the Northern Plains, those which have garnered the largest attention in the media. Most of this attention has emphasized the challenges, namely their vulnerability, the heartbreaking battle to constrain contagion, the lack of resources to care for those afflicted by the virus, and the mounting consequences for individuals, families, and communities. We know that this virus has deeply penetrated tribal communities. Indeed, as of mid-May of this year, American Indians comprised 18% of the COVID-19 related deaths and 11% of the SARS-CoV-2 cases compared to only 4% of its total population in Arizona. That's 7% of cases compared to 9% of the total population on our neighbors to the south in New Mexico, and 30% of the cases compared to only 2% of the population in our neighbors in Wyoming to the north. So within the same time frame, the Indian Health Services reported nearly 6,000 positive cases in IHS, tribal and urban Indian healthcare facilities. Indeed, the infection rate among the Dene, the Navajos, surpassed the state of New York, the center of the pandemic here in the United States until recently, with over 2,700 cases per 100,000 people compared to 18,000. Today, the Navajo Nation has the highest per capita incidence of COVID-19 infection in the US, despite draconian control measures. And of course, you may or may not realize that within the greater Denver metropolitan area, the two largest tribal communities represented among our native residents include the Navajo or Dene and the Lakota people of South Dakota. This situation is even worse among the smaller tribes in New Mexico particularly. The virus presents elevated risks, as Fernando and Cerise have noted, for Native peoples as well, who experience substantial health disparities. We suffer disproportionately, as Cerise pointed out, to the high prevalence of many of the health conditions that place us at greater risk for serious illness and death if we contract the virus, including diabetes, heart disease, asthma, and obesity. The Indian Health Service is the primary vehicle through which the federal government fulfills its responsibility to provide primary healthcare services to us. However, the Indian Health Service has been chronically underfunded to meet the healthcare needs of Native people. Across the country, for example, 25% of healthcare provider positions are vacant, with 30% vacancy within the Navajo Nation as of 2019. And the Indian Health Service budget only provides $4,000 per capita for healthcare spending. That's less than half of what is spent for federal beneficiaries in the general population, and covers only 16% of the estimated funding needed to address the needs provided, addressed by the IHS federally operated and tribally operated and urban healthcare facilities. Now, the Indian Health Service clinics are located predominantly on or near reservations in rural areas. In Colorado's case, our two tribal communities in the Four Corners area, the Ute Mountain Ute and the Southern Ute, which makes those clinics essentially unavailable to the urban American Indian and Alaska Natives, where as residents of today's cities, we represent more than 72% of the total population of American Indian and Alaska Natives. And the underserved nature of these programs located across our cities is widely documented. As that Athabascan elders' remarks above remind us, American Indian and Alaska Natives are no stranger to epidemics. The current crisis is just one in a long history of deadly viruses to plague Native peoples. Upon the arrival of Europeans in the late 1400s and beyond, introduced smallpox, bubonic plague, chickenpox, measles, diphtheria, influenza, malaria, scarlet fever, typhoid, tuberculosis, and pertussis, diseases to which we Native people bore no natural immunity. The consequences were just devastating, killing an estimated 90% of the population at that point in time, with lingering effects that reverberate in today's world in the form of social and cultural dislocation, historical trauma, and major population migrations. The infectious disease-related mortality contributed to enormous social and cultural upheaval among American and Alaska Natives. We've seen throughout each of those infectious epidemics, entire families, even tribal communities decimated. Many survivors experienced major long-lasting disruptions and dislocations. Not unlike today, quote unquote, blame the victim beliefs are paraded explanations for the vulnerability of Native people to the ravages of these epidemics and to our difficulty in weathering the consequences. From the late 1800s to the early 20th century, when we look at media accounts, we saw words like dirty and illiterate regularly appearing in newspaper accounts of the spread of smallpox, TB, and influenza among American and Alaska Natives. And before one dismisses these attributions as belonging to the distant past, One only need cast back to the 1993 reports of the hantavirus in the Southwest United States, which was initially known as the Navajo plague, Four Corners virus, and the CDC's label, Muerto Canyon hantavirus. The mouse droppings associated with its transmission were linked to descriptions of reservation dwellings as, quote, filthy, squalid, and unhygienic. So stigma abounds in the past and today. And this unfortunate history deeply colors Native people's views of the virus. And we fear the social and cultural disruptions this history has shown to be close companions of such outbreaks. Seldom the masters of our own faith, we're often subject to the external forces imposed upon us by the federal government. So Native people are suspicious of the promises of aids that have been provided that have often proved to be hollowed offerings. And so as a result, communities emphasize self-governance and tribal sovereignty. But I want to close on the same note that Cerise did, that despite these challenges, there are enormous wells of strength and resilience in Indian and Native communities, in which scholars, healthcare professionals, advocates, policymakers, and funders have unique and collective opportunity and obligation to join Native peoples in bringing to bear the strengths of tribal communities, of science, and of past and present lessons from public health to battle this virus. It's not only an opportunity, but I believe it's also a moral imperative. We need to recognize that the broader world of which all of us are a part and to which we can contribute. And this is the challenge we are capable of meeting, in the words of that Athabascan elder. Thank you.
Thank you, Spira. That was wonderful. We may have to ask you for that quote to share with folks too. I know some people are interested, if you don't mind sharing that. Okay, so we've heard a lot already. So I'm going to try to start diving in and unpacking a little bit and hear some other perspectives maybe bouncing off each other. And a reminder to all of our speakers, please go ahead and type in your questions in the chat. We'll try to incorporate them as we go along. So I want to start with a little bit in some of the biases that all of you have talked about here, but start in that historical lens right now, which is, and Cerise, I think you specifically had talked about some of the bias and trust when it comes to the medical provider itself, right, with the community. But I'm interested in if you all could speak to what are some examples and what is your experience of just how clinical trials, experiments, we've talked about smallpox and things like that, have been biased from the beginning in our medical profession, which kind of has set up some inequalities when it comes to understanding the impacts of certain things on different communities of color. Does that make sense? And I would love to see if someone wants to start with that. Maybe Fernando, do you want to chime in? Do you know what I'm talking about? I think about kind of how trials have been set up based on a homogenous group of people, which doesn't apply to necessarily other groups.
Yeah, I think that's a very important question. One way that people tackle this very serious problem is to enhance diversity in the healthcare. So, if you're someone of a minority, racial, or ethnic group, and you get treated by a doctor, or a nurse, or a healthcare provider that shares your cultural beliefs, you're always going to be in a much better place. But I do agree that research-wise, representation is key. There's a letter that was just recently published in the New England Journal of Medicine that actually shows that, for example, the remdesivir trials, which is one of the major antivirals, only 1 or 2% of the people in those trials are either Black or Hispanic or other minority groups. So even in the drugs that we're testing for COVID, there's a huge Caucasian representation. So there are a lot of things that we can do in terms of overrepresenting our workforce and also overrepresenting our research population, to name a few.
Well, Kristen, this question is a great one. And of course, it's had a long history in terms of the National Institutes of Health's biases with respect to clinical trial research. Initially, it excluded not just racial and ethnic minorities, but women, and exclusively focused on males, largely white males. That's being redressed in a number of different ways today under the rubric of the science of inclusion, which is a very robust field of inquiry that holds great promise for making a difference and redressing some of these omissions. But we see them today, not only as Fernando just mentioned in the current trials, but we see urban and rural differences. And we have the same kinds of biases at work in these trials. And so I think that we still have a long ways to go to recognize and to redress these kinds of biases in how we approach such science.
Cerise, do you have anything to add?
You know, and I would just add to this is ensuring that our workforce and researchers are trained around these arenas, that this needs to be infused in all aspects of curriculum. It needs to be ongoing and continuous education around bias, and then also partnering with community on research. We hear about community-based participatory research. There really isn't, to me, in my opinion, any excuse of why there's not that partnership with communities, authentic engagement, establishing the relationships, building the trust. But I have to, Fernando was spot on, but we need to diversify in ensuring that we are engaging and researchers of color into this process.
That leads a little bit into another question that one of our guests had, Rachel Freeman, who was interested in how to build trust and repair relationships, particularly as a pandemic is roaring along. We've all three of you talked a little bit about trust or mistrust. Maybe each of you could take a stab at how do you go about building trust? I think three of you are examples of how you can start to build trust, but it takes time, it takes hard, particularly if there's, you know, history and decades and thousands and hundreds of years of mistrust. So what are some really thoughtful ways that you yourself are building trust, or that others should think about when it comes to building trust?
Well, I'll take a first shot. First off, it means being present and putting yourself in the place of others and being able to suspend judgment about a variety of assumptions that many of us have. All of us have assumptions. But it's the importance of recognizing what those assumptions are, how they may affect what you see and what you look for, how you suspend the judgments related to that, and being there continuously throughout that process, and lending your skills to understanding the circumstances and to advocating on the part of solutions that are best promoted by local key stakeholders.
You know, and I totally agree with that. And what I would add on to that is mobilizing in community. That's why we formed the Colorado Black Health Collaborative. It was to say that, you know, we're tired of seeing the injustice within our community. If we really want to invest, you know, really promote and advance equity in the Black health, we had to mobilize and come together ourselves. And in 2009, that's exactly what we did. And as we're doing this, we're establishing trust, we're creating those mechanisms. We have mechanisms. So as a community, we can vet researchers as they're coming through the process to say, you know, this is a trusted, and be that bridge and that link between community and also research and all the work that's being done. So I think, as Spiro has stated, it's being present, it's continually to be present. We don't parachute in and parachute out, and all of that. It's really simple. How do you build a relationship with anyone? It takes time. It's not all about me and what I need and what I desire. Give me. It needs to be mutually beneficial. And at this point, benefiting the needs of community. What are the desires? What type of research would community members want to engage in? So it's really taking that time to be authentic in how we're even broaching and being sensitive to concepts that we know how to build relationships. We know what it takes. It's just putting it into practice. It's so easy to say, I just don't know. You know, no, we need to break through that and really take the time and establish those relationships.
Yeah, I mean, I agree with what Cerise and Spiro have mentioned. I would say that from the academic perspective, research into the community has always been like, we know what's best for you, and we're going to come and get to you so we can use your data, sort of prove our hypothesis using your population. And then once we get the results, we walked out of there. And people and communities are really tired, both Hispanics and Black communities are tired of academicians coming and saying, you know, you guys are in really bad shape over here, and then walking away and offering no long-term solutions. And part of that is actually, you know, enhanced by the funding cycle, right? People sometimes come with very good intentions, and they start to work on the communities, but then the grants run out. And then the projects don't have self-sustainability and they die out. And that creates a level of distrust in the communities to academic centers that's very pervasive, and it continues till today.
And how does isolation sometimes play into some of this? I know, you know what I mean, if folks feel isolated or if they choose to be isolated, right? Like, what are ways to reach folks to avoid them feeling isolated, or to engage with them if they feel isolated?
Find out why they're choosing to be isolated and mend any past hurts. As academics, we need to go into the community with cultural humility and really try to remedy the past hurts. So there's, and so whenever there's any resistance, when I'm engaging in community, I really need to understand the why, not to say, oh, this community is too hard to work with and they just don't want to work. I need to take another pause, take a step back, especially if we know that these communities are overburdened with disease. We can no longer say that community is too tough and just jump onto our favorite communities, which they like to work with us, they like to partner with us. We have to really take the time and make sure that we are learning and getting an understanding of the why folks are not engaged, and really try to remedy the relationship and walk in that humility to kind of form and build that bridge with the community.
Fernando or Spiro, anything else on the dealing with isolation?
Well, this is one of the great dilemmas for people from our respective communities, in which our lives are collective by nature, and our identity is not just personal, but it's social as well. And so it revolves around the development of that identity, its reinforcement, its maintenance through family and extended family matters. If you look at our healing traditions in Native communities, they're virtually all collective by nature, focused on mobilizing and targeting social support in the context of a variety of symbolic frameworks to repair the rifts in the emotional, psychological, and spiritual aspects of our lives. And so something that requires us to isolate through mitigation practices such as today really are an anathema for Native people. One of the interesting things is seen in the Southwest, particularly how physicians from the biomedical world are now working with traditional healers from tribal communities to develop ways in which mitigation practices can be appropriately incorporated into these ceremonial and ritual practices to enable the latter to move forward and to provide the value that they have historically in our communities. And that's what I think, going back to the Athabascan elders' notion about bringing together the weapons of the Western world together with our traditions in Native communities, is a wonderful example of.
I would say that one of the major problems, Kristen, and to add to my colleagues, at least for the Hispanic community, is that drives to terrible isolation is issues related to migration and legal status. So, as you know, a large proportion of Hispanics are undocumented, and many of them that are even documented, given the public charge policies, are not coming out. And that actually is creating a vicious cycle in which people are getting sick, not coming out, and then thereby infecting other people in the communities and not being able to get help at a timely fashion. So, there are a lot of dangers in policies that make isolation a real problem for Hispanics.
I want to build on one thing Spiro said, if you can comment on, and then I want to transition away, but could you comment a little bit on the integration and the role of traditional knowledge with what is seen sometimes as Western information, and what are some ways that we can support and bring those things together when it makes sense? Spiro, did you want to address that?
Yeah, I'll address it again through an illustrative example. There are several Southwestern tribal communities, for example, that are finding new ways to underscore and to develop social supports. A great example is among Pueblo youth and their outreach to elders. So mask wearing, there's a very high prevalence of wearing masks in many American Indian Alaska Native communities. Why? It's because we value elders, and we have done an enormously important and successful job of communicating to our younger people, particularly, that wearing a mask is not so much about protecting yourself, but about protecting your elders. And you have a basic, essential, critical obligation and responsibility to ensure that that value is enacted in your day-to-day life. And so that's a wonderful example of how to bring together a mitigating practice together with synchronous cultural values.
Thank you. So I want to bring a human element into a question that one of our participants asked. So David asked, And it's a little long, but let's get through it. One terrifying example is encasing past discrimination in treatment through the use of new, either machine learning protocols and algorithms. Those that seem to be data-driven on their face, but they reflect past discrimination in treatment, and then they carry it forward. So how do we avoid that? Cerise, what do you want to take a stab at this?
I would take it to my colleagues first. I thought that.
Okay, Fernando, why don't you start?
You know, that's a really good question. I would say that anytime that you're dealing with data-driven, large, metadata analysis, of course, the data is going to be biased by its inherent structure, which carries all the biases and racist practice of policies and other things. And I don't, the data are the data, right? So I think they're going to tell story, but I think where we can potentially make a difference is how you appraise that information and really value its worth by acknowledging its limitations. But I don't think that you're going to be able to potentially, change some of that information because it already exists. It's the way you actually evaluate it and move it forward, in my view.
Any more tangible of how to move forward with some of the racism that's built into previous historical data, or at least thinking about it moving forward?
Well, I believe that self-reflection and criticality is really key to all of this. I'm impressed by the fact that in training medical students and residents, for the most part, they are well-versed in the assumption that science is objective and omniscient, and then it proceeds without bias when done well. I submit that, in fact, there's bias in everything that we do as human beings. And our challenge is to develop the tools by which to recognize what our own biases are, how they may affect our observation of the world around us, and then subsequently proceed. And I think that that is an educable process. I think it is learnable, but we all too often do not undertake that challenge. And there are all kinds of ways to enact that, and lots of examples I use with my medical students and residents.
And then also when we're thinking about these aspects, we want to look at, because some of the questions I know are coming up, well, what are those ways to look at structural racism? What can we do? And so we've talked about training and education, but within our organizations, what's key is assessing. How is racism infusing our policies, practice, procedures, in our values? So when we think about, we want to be like an anti-racist organization, and we hear folks that are saying it, then what I want to know is, have you assessed your practice? Where is it infused? Are we having this anti-racism work infused in every area and every arena? Is it in your value statements? And so these are the different things within our organizations that can address some of those past discrimination and harms that have worked within communities. And that leads to the continual ongoing learning and education, but you don't know if you do not assess. Where are our gaps? Where are we falling short? Even when we're thinking about our engagement with patients, we should be doing assessments. We should learn and hear from our clients about how are you treated? How were you treated from the moment you walked into the front door to the time that you were seen by your physician? And we should aggregate that data by race, ethnicity to see if there's some different trends. So those are all the tangible practice that we need to do, but we don't want to just collect this data. What's key is after we collect the data, we engage in some sort of practice to go through some sort of organizational change. So one of the key things is we're going to have to stop, pause, and assess, and not assume that we're all doing the great work, because these assumptions is what has led to these inequities. People are thinking, that well-intentioned, they are causing harm. So we need to hear from community, and that's through assessment.
Kristen, I can't help but notice in the chat box, several participants have now offered reparations, for example, as one way to address this, and I strongly disagree. And I disagree because we, American Indian Alaska Native people, have several centuries worth of experience and reparations from the federal government. First off, in the form of treaties, we found that those treaties shrunk in size and shape in terms of the obligations of the federal government to us. We also found that reparations in the late 1950s to a number of tribes, which led to their termination, actually gave the federal government the opportunity to wash its hands of further responsibilities to Native peoples. That reparations allows one to point to and say, I've dealt with this. I no longer have a responsibility in that regard. I've discharged that obligation. And I believe that what we need is an ongoing acknowledgement of that obligation in a reciprocal fashion that keeps us engaged and moving towards solutions. Without that kind of engagement, which I think reparations, for example, undermines, I don't believe that solutions are likely to occur.
Are there good examples of that ongoing engagement that you could point to or that you have ideas about?
Yeah, in some respects, they're specific to American and Alaska Natives, particularly federally recognized tribes, when since executive order, going on back to the first Bush president, they required what was called government-to-government consultation, recognizing that tribes have domestic dependent sovereignty status and the federal government has a responsibility to engage us and to consult with us about a full spectrum of different kinds of policies and practices that affect our lives or hold promise affecting our lives. So we're engaged. That doesn't mean that reparations aren't occurring simultaneously, but they're a necessary but not sufficient condition to achieve the kinds of goals that I think that we share.
I'll let my other speakers comment. I know, Fernando, you had brought up reparations too in some of your introductory remarks. Do you have further thoughts on that?
You know, I think my colleagues have a lot more experience than I do in terms of reparations, but I would say that whereas there's perhaps been a lot of discussions and engagement with the Native American community, it seems to me, and this may be my only opinion, but it seems to me like, for example, that discussion hasn't even happened for the Black community in this country yet. It hasn't even started. And so I think there's a lot of work to be done.
I would completely agree on what that conversation would look like. And yeah, we're still, what was it, 3 carts and a mule? We still hadn't even got that. So I'm just saying that that conversation has not moved forward within the Black community.
So we are going to hopefully wrap up here in about 9 minutes, but so let's take this a little bit bigger into really right now what's happening with what are we learning, or it's an ongoing learning with COVID-19, right? On a day-to-day basis, every time I turn around, I know I'm learning something new. What are we learning now in respect to taking in historical examples that we can learn from that can help us make ourselves a little bit more prepared, even to deal with COVID-19, which is still here and still raging and still growing, but then thinking about the future aspects of future pandemics, future diseases. What are some things that you think we're learning about right now in regards to different communities of color, different Native and Indigenous communities, different racial and ethnic communities? What are we learning that we should really take to heart?
Kristen, I'll start. I will say that people need to understand that epidemics are apolitical, right? I mean, you have to understand that this process is only response to really 2 things: to public health interventions that are based on evidence, and that it highlights the social and structural inequities that exist not only in these countries but in many countries. And unfortunately, when you look at the historical records from the 1918 flu, or even from the cholera or the plague epidemics, the same type of mistakes get repeated again and again and again. Things becomes highly politicized. There's a lot of misinformation happening now with the internet, even more broader and more rapidly than it has in the past. But clearly we have to be conscious to the fact that we, as Dr. Manson mentioned, we need to care for our communities. One of the problems that I have is that I know that the United States has a lot of cherishes individual freedom quite highly, something that's very valued in this society, but we have to think about collective freedom as well. If I don't protect my neighbors and my neighbors get sick, what does that get me ultimately? So we have to think more collectively and a society, sometimes perhaps more than our own individual health when we're dealing with problems like this.
What my hope is in this, and what we're taking away, is that history is repeating itself, that we're not making much change. And so I imagine that when Dr. King was assassinated, folks were moved, and all these different things, and when injustice. And now what happened afterwards, there wasn't much change. And so what my concern is if we're not conscious, history will repeat itself again. We have folks that are talking about racism. We have all these structural racism. We have all these statements which can be deemed as performative if we are not intentionally thinking of how we're going to change our practice. So I'm more hopeful that this isn't just a moment of time, and after COVID, we go on to the next aspect. And communities of color who have been historically marginalized, all of these groups have a history of marginalization in the United States, does not continue to move forward for the next 100 years. So that's kind of the way that I'm framing it. We know clearly it's due to the inequities and all this. Call it out, make the changes, and do something. We got to do the work.
My view on this is that expertise and knowledge does not reside within the world of science alone. That there are many, many different locations of relevant expertise and knowledge that we need to be open to, identify, solicit, engage, and then integrate into the ways in which we battle these kinds of infectious disease epidemics. And I think there are some wonderful examples. What it requires is that we be open to those possibilities and that we explore actively where that knowledge and expertise lies and engage it in mutually beneficial and meaningful terms. And I don't think we've been historically particularly adept at doing that.
I agree. Let's end on the theme of resilience and resiliency. And we actually had a really nice question from one of our audience members, Renata, about what is the one thing that you do to maintain your resilience? And then of course, how often do you do it? So whether that's something that you do personally to maintain resilience, or if you're not comfortable with that, something that you've seen a community do to maintain resilience would be nice too. I'm looking around, who wants to start? Cerise, do you want to start for me?
You know, I'm all about self-care because in this time, in this season, really taking the time to refuel, you know, disconnect, because there's so much that's going on. And I think about all that's going on, the civil unrest in the United States, is global unrest that's going on, is the self-care. But what has also, as someone who has gone and done all their education in predominantly white spaces, it's been my community. We gotta allow for affinity groups to engage and come together and not be concerned about that, because my engagement with the Black community, being connected to the Colorado Black Health Collaborative, that connection to my community allows me to refuel and replenish. It gives me the space to kind of identify with other scholars, with other community members, to really refuel me. And I think that that's important. Do we have these spaces? It's so important for our community just to band together, because like in Colorado, in Denver, we don't have like a Black neighborhood. So it's gonna be, when we're talking about convening and come together as a Black community, we have to be intentional. And so creating those space for Blacks to come together, strategize, and just heal with one another in this shared experience.
You know, I would agree, Cerise. I think for me, resilience in the community has to do about the value of your identity in a community. And I think that comes, you know, in the Hispanic community in particular, there's a lot of family-centeredness. And Hispanics in particular have been an ethnicity group in the United States, for example, that has, even though they share words in terms of having access to healthcare and having higher risk of chronic diseases, they often have better outcomes in terms of survival and other things compared to even Caucasians. So there's a lot of incredible amount of resilience among the Hispanic community, which is a shared cultural background, even though it's very different in many different Hispanic subgroups. I think that's where resilience comes from. Personally, I think my resilience comes from being inspired by the stories of my patients and their struggles. And I learn from that every day and inspires me.
With respect to resilience, I think I've spoken hopefully repeatedly about what I believe are many of the strengths and assets and sources of resilience in Native communities. Personally, I'm very blessed to be able to live on a ranch about 75 miles southeast of Denver. That was a decision I made 20 years ago of how to bring work-life balance into my professional and personal worlds. I'm like Fernando and Cerise, I'm able to integrate my personal and professional lives so that everything I do personally really echoes in my professional life and vice versa. So Fernando's point about family-based and family-centeredness of the Hispanic community is also true. So I had my daughter and son-in-law and 3 of my 4 grandchildren here for 5 days for horse camp, in which we let the broader world go by, and we rode together across the ranch every afternoon for 3 to 4 hours. I just returned from a trip to Alaska with my oldest son, who's a U.S. Marshal, who's been at this strange interface between law enforcement, social justice, and many of the racial and ethnic tensions that arise. He himself, being American Indian and a U.S. Marshal, is challenged by these kinds of tensions. So I agree with Fernando, and Cerise said it earlier, it's family-based from my point of view.
Thank you. I appreciate all of you for your time today, for sharing your expertise, for being very direct, being very honest, providing inspiration, and sharing a little bit about your personal lives too. Because often I think scientists, those that we work with are, you know what I mean, this group over here, and we're all human. And we're all trying to figure this out. We're trying to learn from history to not repeat history, even though we are. And so I like the idea of a lot of what you all said, including that intentionality, and then being, of course, resilient. So thank you tremendously for being the people you are, for the work that you're doing, for helping myself and my colleagues put this together. This was definitely, you know what I mean, useful for myself. Hopefully all of our audience found it useful. We've got a long road to go to continue to learn, continue to act, continue to do better. And so I really appreciate you all helping us put this together. Thank you for that. We're going to go ahead and wrap up for today. Just as a reminder to all of our participants, we have a second part of this conversation with some different voices next Monday at 8:30 as well. So we encourage you to kind of keep your eye out for that registration. Tune in for that. You know where to find us on the Institute website. You can also follow all of us on social media to stay up to date on the latest of what's going on with this series. So thank you, Cerise. Thank you, Fernando. Thank you, Spiro. Thank you to my colleagues at the Colorado School of Public Health, in particular, Dean John Samet, for helping put this together. All of my museum colleagues who've worked tirelessly behind the scenes as well. I hope you all stay healthy, stay safe, both for you, your families, and your communities. And be kind. I want to leave you with thinking about looking for that trusted sources of information, wherever that is. There's a lot of information coming out at us, including a lot of misinformation. So I encourage you to be a little diligent when you think about where are you finding information that you use and take back for yourselves and your families and communities. So thank you for that, and I hope you all have a wonderful rest of your Monday.